It's important to remember the thoracolumbar injury classification system called TLICS. So there are three independent factors similar like SLICS, that is morphology, integrity of the posterior longish complex, and neurology. Regarding the morphology, 1 is compression, 2 is burst, 3 is flexion, 3 is translation rotation, 4th is retraction. Another is posterior longitudinal complex integrity. 0 is intact, 2 is suspected, and 3 is injured. And third is neurological status, which is intact 0, nerve root injury 2, complete cord injury 2, incomplete cord injury 3, and cardiac venous 3. Any score which is more than 4, as per Khorana et al. In 2018, needs surgical intervention. Anything which scores 4 is surgeon choice, and 0 to 3 should be managed non-operatively. A CT scan in thoracic and lumbar spine can predict posterior longitudinal complex injury by considering following. Number 1, vertebral translation. Number 2, pedicle or lamina fracture. Number 3, interspinous widening. Number 4, spinous process fracture. If one finding is on CT, it is recommended to get MRI, as superficial specifically for posterior complex injury is only 59%. But if more than 2 findings on CT, MRS can be avoided. MRI scan is also important to identify disc injury, epidural hematoma, and posterior longitudinal complex injury. Kim et al. Showed thoracolumbar lumbar spine fracture stable if the kyphosis is less than 30 degrees, vertebral height loss is less than 50 degrees, canal encroachment is less than 50 degrees, the facets are intact, PLC is intact, and neurology is intact.